Thank you. Welcome everybody to our post-discharge follow-up work group today, September 10th. My name is Emily Bear and I'm one of the site engagement coordinators with MVC. Hopefully everybody can see my screen right now. I'm going to go through a couple of housekeeping items, one survey question, and then I will introduce our speaker, Brian Leideker. All right. So just a couple of housekeeping notes. This session is being recorded. The slides and the recording will be shared with all of the attendees today following the work group. Just give me a couple of minutes to pull that recording together, as well as the email, and that will be sent out to you. We will be monitoring the chat throughout the presentation from Brian today. So please hold your questions until the end, but we will definitely make sure to have an opportunity for you to ask questions of our presenter. And then lastly, we will be providing you with the survey link to provide some feedback on this work group after the completion of the presentation. Your feedback is very important to us. But also remembering that for credit for attendance to this work group session, for those of you participating in P4P, we will need to receive a survey, and that survey can only be completed for one hospital site. All right, now let's see if my poll works. So for work groups in 2025, we were curious to know if the timing of these work groups is working out well for everybody. So bear with me while I pull up this. Of course, everything looks different. Okay, so hopefully a poll has launched on your screen. The first question, we're just wondering what time of these options, 10 a.m., 12 p.m. noon, 2 p.m., or 4 p.m. potentially might work best for you for work groups in 2025. Of note, we are likely going to be maintaining this Tuesday, Thursday, kind of the second Tuesday and the third to fourth Thursday of the month kind of schedule. And if anybody has any other times outside of that 10 a.m., 12 p.m., 2 p.m., and 4 p.m. Options, there is a fill in the blank under question 2. I see some people have taken advantage of that. Give you 30 more seconds. I'm still seeing the numbers move. Okay, awesome. Thank you so much for participating in that poll. And we will take those results into consideration. All right. All right, so today's presenter is Brian Leideker. Brian currently serves as the COPD Navigator for Trinity Health Oakland in Pontiac, Michigan. His work involves optimizing care processes, transitions of care, patient education, and developing staff and resident education. Prior to this current role, Brian worked as a respiratory therapist in a variety of different clinical units, including med-surg, PICU, NICU, and various other ICUs. So thank you so much for being with us today, Brian. I am actually going to progress Brian's slides, so give me 1 second while I transition over to his slide deck. Okay, hopefully everybody can see Brian's beautiful slides now. And Brian, you just let me know when you're ready for me to progress them.
Yeah, you can go ahead.
Okay.
You can go to the next slide. Hi, everybody. I'm Brian, one of the respiratory therapists over at Trinity Health Oakland. You can go to the next slide. We have no financial disclosure relationships to disclose here. We have a little bit of an agenda here. We're going to look at some data, some readmission data, some of the works that we've done in progress here at our facility, care across the continuum, what we've been working on, and then we're going to wrap it up with some MVC reporting data that we were able to pull. So I appreciate that from MVC. Next slide. So, readmission rates are always going to be, hit or miss in different types of hospitals. And, we have certain barriers at ours in particular, working over in Pontiac. On the left side, we see CMS Medicare fee for service slightly trending up here in 2022. I put a little star right there that actually is kind of showing at the time that we created this A3 for a COPD readmission steering committee that started at that time. So basically, I got involved at that star there, specifically to help reduce COPD readmissions. On the left side here was MVC all-cause data, showing that, in 2022, 2021 obviously was down COVID time, and then we started seeing an uptick here in 2022 to 2023. Next slide. The work that we've done thus far since that time shows, we are helping to reduce readmissions for COPD. On the all payer on the left side here, we have successfully brought this down below 20% as of May of 2024, which is cool. Medicare fee for service rolling 6 month, it's showing a lot better as well. So we are happy to see some of these things that we're doing here in the hospital seem to be having some type of an effect. Don't know if that is because of what we're doing, but we're hopeful. You can go to the next slide here. Next slide. So some of the works in progress, just a little bit of background about why the A3 was created, with COPD just becoming an ongoing problem here. This really was the first time where we had considered bringing a respiratory therapist into the case management outcomes department, where we now had a respiratory therapist that was actually looking at processes on the medical side, with working directly with case managers, specifically for discharge planning. I still am doing basically all the evidence-based findings that you're going to see as far as, MDI, treatments, education, smoking cessation, delivering all that patient education bedside is something I'm doing. I have built certain types of handouts that I give as kind of like a patient-specific type of education. I highlight potential causes for readmissions. I collaborate between the disciplines. So think of me as a middleman between respiratory, physician, CM, and other entities, all trying to kind of how to deliver and support evidence-based practices for our patients here. Next slide. I was conducting RCAs. So basically what I was showing was for the 3 years of following all of these readmissions for COPD, I kind of found one common factor about what could have possibly have been the reason for these patients coming back to the hospital. Over 90% of all of the patients readmitted to the hospital with a COPD DRG were due to some type of intended continuation. I put it in bold there, intended continuation of pharmacological or a non-pharmacotherapy that was abruptly interrupted. So basically it meant that we had all the intended efforts of making sure that the patients were given every opportunity, but for one reason or another, we fell short. Okay, we weren't able to get them a LABA/LAMA inhaled corticosteroid, the medication that they needed to stay out of the hospital. We didn't have supplemental oxygen. We were doing processes wrong. For one reason, we thought that they were going to, meet these qualifications. They were going to meet medical necessity, but we have to find that medical necessity in 24 to 48 hours, which is a very short time frame to kind of figure this stuff out quickly. Non-invasive positive pressure ventilation was also one of the biggest contributors here. CPAP, BiPAP, non-invasive ventilation. We had intended for it to continue at next site of care, but communication just fell short. So my focused attention was specifically on those three over the last 3 years. Next slide. Talking more about the observed breakdowns. So when we were discharging to a skilled nursing facility, our communication that we were providing the next site of care needed a lot of work, and there's still a lot of work to be done. Meeting those transitions to care, those follow-ups, we were doing follow-up phone calls. A lot of patients in Pontiac, they don't pick up the phone. That everyone's afraid of picking up different numbers nowadays. Post-discharge support of DME equipment. I began kind of keeping track of DME services, the companies that are involved in supplying and supporting these patients of ours. I'm trying to hold them at a higher expectation. I feel like it is working. I think that they do play a major part in the services that these patients could be utilizing after our discharge from the hospitalization. But more importantly, what we're going to focus on is the denials of the DME services at discharge. I was finding out that our processes inside our hospital, where we were doing them incorrectly, basically. Certain departments didn't know that certain studies were going on to meet medical necessity. So I had to do a lot of investigating and a lot of fact finding and finding out where the breakdowns were within the hospital. Next slide. So just to rehash, like all of this, as far as evidence-based, this is taken from the gold here standard here. Adjusting pharmacological therapy and non-pharmacological therapy is part of this evidence-based practice. And I kind of circled there down at the bottom here, a need for oxygen and non-invasive ventilation. It's a constant revolving door. We need to be getting these services to our patients, and we have to make sure we're tracking them. We have to making sure that they know how to utilize them. They know that they have the support for them, and they know that they need to be titrated in the real time to meet their need for whatever they're doing outside the hospital. Next slide. Some of the things that we've done that has, I feel like, has helped increase communication. This is just one of, I think, 3 different types of documentation changes that I've made, where I'm basically leveraging Epic and smart phrases to kind of quickly capture information when I do my bedside education. Specifically talking about ambulatory medication review. So doing a very quick review of the patient's knowledge of their medications. I'm assessing their route of delivery. So we're comparing handhelds versus nebulized therapies, see what their barriers were to handhelds, why they could be in. Do they have a nebulizer at home? Is it in good working condition? Are their medications affordable? I'm trying to address all of these barriers quickly. Because a lot of these barriers are found that we need to document on these in order to open up access for other types of therapy, like a different type of inhaler. A lot of insurance companies won't consider covering them unless they've failed another form of therapy. In the area that we're working at within Pontiac, follow-up care is a challenge. So there isn't a lot of follow-up care to help provide that documentation. So we're trying to do a better job at capturing that during their hospitalizations as well for the physicians to consider at discharge. Next slide. You can keep on kind of branching. I think it's just kind of, logic that I put there. We'll keep going there. Almost. Let's a brief idea of what some of the handouts look like. We were using a traffic light, which I'm pretty sure just about every hospital has kind of got on board with. We have 3 other handouts that I made. Was a freedom from smoking. I made changes to our MDI inhaler guide, added QR codes, and I also made a hydration, humidity, and lung function handout with some QR codes. But specifically talking about the DME equipment and how the DME equipment could be giving the patients at home, putting them in different situations if they're prone to nosebleeds or nasal congestion or sinusitis or rhinitis. What if they had this equipment in their home, what could they do to help their situation if they're suffering from those things from them? Next slide. The workflow processes that really I was really trying to hone in on here was the home O2 eval and 6-minute walk test, and the overnight oximetry study. What we were finding was when we were trying to meet medical necessity within 24 to 48 hours from discharge, we were attempting to get or find medical necessity by performing an O2 eval. We'd go into the patient's room, we'd remove the oxygen, and then we check their pulse ox. At most hospitals that I'm aware of, this is usually scoped to a respiratory therapist. It's been scoped to our nursing department here for years, which in my own opinion was one of the major barriers to that success. There are pretty strict guidelines on performing 6-minute walk tests and home O2 evals, but more importantly, in the COPD patient population, the 6-minute walk test and home O2 eval, it was so imperative that that was done correctly and done a certain way. And every time I talk to a nurse, and I give them feedback on what patients tell me, there's always one silly thing that patients that smoke or that have, that have quit, have more than several occasions have said, they can still see their smoke coming out of their lung an hour after they put a cigarette down. So they're still blowing smoke an hour after they're done smoking a cigarette. So I use that, what do you call it? Not a strategy, but an example of replace that cigarette smoke with oxygen, okay? If they're using oxygen and then we remove oxygen to do a walk test or to check an oxygenation status, we're trying to simulate their home environment when we do these things. We have to be stressing them if they have stairs, if they, if they have long walking distances. Our process is we were just taking it off quickly, walking them, and then they wouldn't desat. We weren't stressing their body enough to what they were doing, like basically to simulate their home environment. So we attempted to run a pilot to rescope this to RT. It failed miserably, but it really kind of highlighted an important part that we really had limited bandwidth from our RT department. So I think there's still a lot of opportunity with that. Overnight oximetry study, super important. And I'll be honest, I'm arrogant to this because or you call it ignorant, but I've been an RT for 10 years, longer than that, but working at St. Joe's, Oakland. And I had no idea that these overnight oximetry studies were used for medical necessity to obtain a BiPAP or non-invasive ventilator. I had no reason that was the reason for that. So once I was brought in on this A3, I started kind of understanding a little bit more about medical necessity in the last 24 to 48 hours and started realizing, oh my God, we have been messing this up for years, and as soon as we kind of tweak some processes, we're super successful now at obtaining medical necessity now for these patients. We're communicating a lot better in the hospital with nursing and case management and the respiratory department and the physicians as well. Everyone's talking about the same things. Everyone's trying to describe BiPAP and CPAP and non-invasive ventilation the same way. It is a huge challenge, though. It places the patients at risk for those that don't know the difference between CPAP and BiPAP. So we still have a lot of work to do, but it is definitely getting a lot better. Next slide. Transitions of care. So some of the other things that I was involved with, I was happy to be involved with. Belinda is on this call also, which I've been blessed to kind of work with her, and she was able to bring me in here. Working with trying to educate the skilled nursing facilities and home health cares here in Michigan that are affiliated with Trinity Health systems here, just working together that get everybody on the same page to improve communication when talking about COPD patients regarding medications, the LABA/LAMA inhaled steroids, oxygen, and non-invasive ventilation, known as CPAP, BiPAP, and NIV. We just kept dropping the ball with the communication. So it's been very, very nice to be able to get the feedback from those skilled nursing facilities and the home health care sites, in the PCP offices, and see like, how do we all kind of improve our processes and help each other kind of communicate, and do what's best for the patient. Next slide. Developing education. This is just touching on the education that we did roll out. So we're talking about COPD, and then we're also talking about chronic hypercapnic respiratory failure, and then safe use of CPAP, BiPAP, and non-invasive ventilation here. You can go to the next slide. So I've been doing this. We've been trying to improve our processes, and now we actually, for the first time, we're able to kind of gather a little bit of data and see where we're at now. And I know that this is all about follow-up rates. So I was trying to now compare how well do we obtain DME at discharge, right? And then if we did obtain that DME, whether it be oxygen or a BiPAP or non-invasive ventilator, there should have been some form of follow-up after that. It is necessary for physicians to follow up with these patients for them to continue using their equipment. If there wasn't that type of follow-up, then the DME companies were supposed to be getting involved in reaching out to physician and advocating for that and saying we need to get them in there to see if they're still benefiting from these devices. Do they need a sleep titration study and whatnot? Next slide. So MVC DME volume data on the left side here, we're talking specifically about DME post-discharge data. Looks like we're slowly had a steady increase of. Now on the left side, this is very difficult for me to interpret on the left graph, but on the right graph is something I can relate with. But DME post-discharge data in general is slowly improving. On the right, we have our post-discharge data specifically breaking down the DME of BiPAP and non-invasive ventilator. And if you could turn your attention to the gray for E466 post-discharge, you're going to notice that there was a steady increase in utilization from 2020 to 2023 at a utilization of almost 10%. This is super important because the COPD patient population, it is known that BiPAP is necessary to treat hypercapnic respiratory failure, but because of the aggressive set pressures of BiPAP, this is another reason why patients could also fail BiPAP with COPD. So we were trying to capture a lot of that failure by asking the patients a lot of questions. Why aren't you wearing it? What are you wearing? How are you doing with it? Are you improving? Are you being readmitted? And then just kind of gathering the documentation for physicians to make decisions here. Next slide. The MVC follow-up rates from 2020 to 2023, of staying above benchmark, which is good. I'm not mad at that at all here. The next slide is a little more interesting, and where I think the opportunity is to kind of help the certain type of patient populations that we're struggling with here in Pontiac. You'll notice here in 2021, our Medicaid follow-up rate kind of plummeted there. I really think that non-invasive ventilation and BiPAP, getting these patients these services as quick as possible can help kind of increase their quality of life and help improve the follow-up care within the physician's offices. It's just really a matter of getting the equipment to their patients and getting these discharge services in place here when deemed medically necessary. I think that's it. Next slide here. I think that's, yeah. It's pretty close to 12:30. Okay. So yes. Yeah, questions.
Wonderful. Thank you so much, Brian. That was really informative. And I think you touched on a lot of really important points here. Are there any questions from our participants today? Don't believe I saw anything come through on the chat yet, so you're welcome to unmute yourself and ask your question out loud, or if you would prefer to write it into the chat, we can read them out for you.
And while we're waiting for folks to put in their questions or unmute themselves, I have a question for the group, because Brian, this is great work, and I used to work in care management. We did not engage with respiratory therapy in this way is a very novel idea in my mind. I'm wondering if there are other sites that are doing similar as you guys are with involving a respiratory therapist for these patients, or even other specialties. If you've got clinicians that aren't traditionally involved with care management that you've included, I'd love to hear about that. If you want to either just also put that in the chat or unmute yourself and tell us a little more about it.
Looks like you did have a question come in the chat. Do you use home healthcare services for post-discharge patients on a regular basis? I'll be honest, no. I think that the utilization rate of home healthcare strictly for COPD is relatively low, just because of the fact that there's certain requirements and restrictions for this type of patient. One being is the patient homebound. And I don't work too much with the case management as far as getting involved with what services are ultimately going to be provided. I'm really just trying to make sure that if the physician did want a service, that we are successful at delivering that service at the discharge. But there is a lot of opportunity to use home health care services for COPD patients. Also, pulmonary rehab as well, which we are just about to open up our pulmonary rehab, by the way, which is great. Has been closed since COVID. Do you help contact patients to pulmonary rehab? Oh, okay. So that's the next question here. Yeah. So our pulmonary rehab, we had a remodel. Our cardiac rehab was remodeled prior to COVID. It got put on the burner, and then now it's all finished up. Cardiac rehab moved, and there was like a 2-year delay with getting pulmonary rehab started back up. Some logistics of patient just processing and scheduling conflicts and whatnot with oh my goodness, what's the department that does all these scheduling and stuff? I forget the name already. But anyways, it was basically just another poor breakdown for the reason why we couldn't get it off the ground. So I'm happy to hear it is going to get off the ground. Brian, do you know how you get patients' family engaged more with education management? Oh, that's a good question, Belinda. So I have had some asks from certain DME companies, particularly Vincent's, in here to help get it more involved with setting up some types of workshops. I'm offering patients to bring their equipment into the hospital and sit with them. There's a lot of stress involved in some of this equipment when family members are providing the equipment to their loved ones. Their anxiety goes up, they make mistakes, specifically with the challenges of when to transition from wearing a mask back to a nasal cannula. They make mistakes, they forget to plug the oxygen back into the concentrator or vice versa. Yeah, so I think that there's a lot of opportunity to continue to engage more with the patients, patient's family specifically. Do you use patient advocates that connect to newer COPD patients that can offer tips? No, not in particular. I do have cards. I get a lot of people reaching out to contact me, and they're allowed to call me. So I do connect with a lot of newer COPD patients. I do follow COPD within the hospital throughout the week as well, specifically targeting their DRG, their working DRG. So I know exactly that they're being COPD patients, so they can, whatever I do with that patient should follow that COPD pathway. So I'm constantly looking at patients. My patient list since I started is up to about 800 patients from 3 years ago. So it's an ongoing thing here. If the patient, please note if the patient meets home health care criteria and accepts home health care referrals, some agencies offer a COPD care pathway. Yeah, I'm seeing more COPD programs opening up, which is nice to see. Yeah. I'm hoping that the work that gets involved is just going to continue to kind of get better, over the years but more importantly, just working together, home health care, DME companies, and the hospitals working together to kind of take care of these patients and improve communication. It's very, very difficult, just given the different platforms that people are using for their EMR. Belinda, also, have you noticed any challenges with drug coverage post-discharge? Yeah, it still is a problem. It just insurers, they don't see a real reason to pay out for something if they have already paid out within that 30-day window, which is understandable. And all of a sudden they're failing something, or the hospital writes a new prescription for something that they've already paid out. I mean, it makes sense. We have to do a better job at finding the medical necessity of why that drug is so important versus the other one. And we have to do a better job at documenting that for the patients, particularly handheld. Evidence-based practice shows that handheld therapy is great, but the patient has to be able to perform that 100% of the time with perfect efficiency or efficacy. A lot of these patients have arthritis or have post-strokes that they were a COPD patient. They can no longer have the hand-eye coordination. We go to order them a nebulizer or get nebulized breathing treatments, and insurance or the payer is denying this because we have to jump through hoops to get the medical necessity documented on why we needed to go nebulizer route versus handheld therapy. So trying to do a lot of work at kind of increasing everyone's base knowledge on how to document medical necessity and what questions we're looking for to ask the patients to find those barriers to those drug therapies. Any other questions?
Well, Brian, you did my job of reading out all those questions.
I'm sorry.
So you're good. Thank you. We blew through those. So if there are any other questions, feel free to put them in the chat or unmute yourself. Give me a moment here. I guess I'm curious, Brian, you've touched on a lot of different areas that are sort of like the next steps or the next areas that, maybe need to work on communication or improved access. What do you see as like the most important next step for you to take from here moving forward? Like, what is that? The one golden ticket thing?
Well, my big personal want that needs to happen is to improve the way that CPAP, BiPAP, and non-invasive ventilation is perceived by all disciplines. It's just super confusing. It involves a higher level of technicality. Even physicians have a hard time really wrapping their brain around non-invasive ventilation. A lot of this has to do with the fact that so many companies popped up and there's so many different acronyms for the way that we're presenting this type of information. It's super confusing, and I'm trying to now work on just how to create a more unified approach to say, hey, are you on this or this, instead of them kind of just being blended all into one.
Sure.
That is my biggest one. My second is really to continue to work with each department within the hospital and just make suggestions on how to target certain evaluations that they're performing at discharge to put these types of patients in a better position to be successful. If I could offer really a couple days ago, I just talked to the physical therapy team lead, really to just plant a seed about how they evaluate their patients, how are they walking their patients when PT is consulted. If the patients have stairs at home, or if they're doing a load-bearing work every single day, it's not necessarily fair that we're binding, whether or not they meet oxygen just by simply performing a walk test. Why don't we incorporate some load bearing? Why don't we do some stairs in that? Because that is going to simulate and give a better status before discharge. And if it shows that the patients need oxygen while they're performing these stressful, whatever they're doing at work or stairs, getting into their apartment. In Pontiac, we have a lot of high-rise apartments and a lot of stairs, So if they desat during those stairs, well, then they meet medical necessity for oxygen. That's just not something that we're doing enough of. So I'm hopeful that that's going to help a lot of other patients, in that regard for discharge. So those two things.
Great. That was awesome. Sounds like still a lot of work to go, but you've made some progress thus far. I didn't see any other. Oh, maybe one more. Marjorie, are you finding any significant impact of sleep apnea with COPD?
Yeah, so that's an interesting question. I am working with some of the senior leadership really to try to do a better job at evaluating sleep disturbance within the hospital using PMD monitoring. Um, I don't know where that is going, where it's going from, but basically by investigating the whole overnight oximetry study through RT, I was finding that there was still more communication breakdowns in um, how are we monitoring patients? How are we finding out whether or not they have this need in the hospital? As far as sleep apnea is concerned, we don't perform sleep studies in our hospital. We do perform overnight oximetry studies using oximetry technology, but there is a lot of room for improvement to increase or to improve that technology and then get it more towards sleep apnea and obstructive process using different types of equipment. So I'm hopeful that maybe some of that will change in the near future. If that does, we'll be able to identify certain obstruction of sleep apnea or sleep disorder while hospitalized, which would help give us a better understanding of what type of services to offer them at discharge. Does this person meet medical necessity to now have a sleep study done? Do they meet medical necessity for nocturnal oxygen? These are questions that we need to have supporting documentation and evidence behind. We just got to really get better at our own processes of how we're evaluating patients, for these specific services, and once we improve those, we can make a bigger impact. And it could impact CPAP. Yes, yeah. So that is, yeah, so I kind of have this pathway. It's like my 6-month plan out, but it was basically to help identify sleep disorder. First with a stop bang. So a physician would do a stop bang score, and depending on what that stop bang score would look like, that would give them truth to order an overnight or sleep apnea study performed by RT. If those studies represented desaturation less than 88%, for 5 minutes cumulatively, then that would say, oh, okay, I'm going to order a sleep study for you or an at-home sleep study. There is a very big problem with access to sleep lab with certain types of patients. What I mean by that is if we wanted somebody to get into a sleep lab, let's say they have sleep disorder, they go and they do a follow-up or they make that phone call. Well, a lot of times these sleep studies, at these sleep labs, they're 2-3 months out. And what we're finding is a lot of these patients are in and out of the hospital 5-6 times before that ever happens. But if we created some type of pathway where we found medical necessity for an at-home sleep test, and then we ordered that through the ambulatory services, and then that was performed at discharge, if that patient came back, they would have a sleep study under their belt, which now we could actually provide CPAP at discharge, which is something that we've never been able to really provide at discharge from a hospital visit. There's a lot of other moving parts behind all that, but I'm hopeful that we just improve our processes and try to open the door for more services for the patients.
Sounds great. All right. We're getting some thank yous. I am going to take back the screen here. 1 second. All right, hopefully everybody can see my screen again. So just a reminder, our last post-discharge follow-up work group of the series for 2024 is scheduled for December 3rd at noon. If you still need to register for that, you can find that link on our website on our events page. As a reminder, post-discharge follow-up attendees, if we are looking for P4P credit, we do need to attend all 4 of the work groups in this series. So if you've attended 3 of 3 so far, we hope to see you in December. All right. Just a next slide here. All right. And then our most upcoming work groups, we've got a rural health work group scheduled for September 26th. We have a presentation from Brent McCullough from My Michigan Health, as well as a health in action work group on October 8th. That'll be a presentation from Jesse DeVito from Michigan Medicine. As a reminder, all of those work groups are at noon currently. And we'll evaluate the results of that survey that everybody so graciously did for me at the beginning of this work group to see if that remains in 2025. All right. And with that, if you have any questions, feel free to reach out to us at Michigan Valley Collaborative at med.umich.edu and be on the lookout for the follow-up email from me a little bit later today. All right, Jessica, can you make sure we've got that link in the chat for the survey?
It's there. Yeah, it's that
Awesome.
post that I have there.
Awesome. And we'll leave that there for a minute here. Thank you for attending our work group.
Thank you so much.